Boa noite a todos, pessoal. Hello, everybody. Well, I think we can start.
Okay.
Okay. Well, welcome, everybody. It's a great pleasure to have all of you here, and in special Dr. Kaplan, that is a very important neurologist and stroke neurologist from Harvard. It's really a great pleasure to have you here with us today, Dr. Kaplan. The first question is, usually, what is your choice to treat a stroke caused by a spontaneous extracranial arterial dissection? Aspirin, aspirin plus clopidogrel, anticoagulation, endovascular treatment? You can vote, just to know.
So aspirin and anticoagulation, 42%, both. Okay.
Okay. Okay, so Dr. Kaplan, you can start your presentation, and after we will discuss about the treatment. Perfect, Dr. Kaplan, you can see.
Okay, so first I just want to greet all my friends and colleagues from Brazil. I've been treated wonderfully there and always look forward to coming to Brazil. Unfortunately, I think both our countries have really suffered from this terrible scourge. And I think we all hope and pray that in the future, at least our leaders will have the ingenuity, the empathy, and the wisdom to lead us in the right direction. I think we all hope and pray that. It'd be nice to meet again, either in the United States or in Brazil somewhere. So I'm going to start with a picture, and actually my presentation is loaded with pictures mostly. I think a picture is worth 1,000 words. I'm also not going to say a lot at the beginning about treatment, and we'll have a discussion about that, I think, which will be important, because my feeling is there's not one answer, that it depends a lot on what's wrong with the patient and the patient's details of which agent you choose. So this is a picture showing on the right here blood within the arterial wall. And I think there's good evidence that when you get a dissection, the thing that starts is blood within the arterial wall. And in some patients just have blood within the wall. Now, if the bleeding is large, then there is compression of the lumen. And what often happens is there's a tear, and the tear joins the blood in the wall with the blood in the lumen. It's loose, it's not organized, it can easily embolize, and the lumen is often compressed. So when we look at the pathology, it begins with a tear. Stretching makes a tear in the arterial wall. It causes an intramural hematoma. Then that lumen can be narrowed or occluded, decreasing blood flow within it. And clot forms within the lumen, and that clot can easily embolize. So it can do it by either the intramural hematoma dissecting into the lumen, or the intima is perturbed. So you get a release of tissue factors, there's slow flow, so a clot can actually form within the lumen itself. So this is a picture, and I think it's important to realize that there are differences. So the dissection can occur, as you see on the left, between the intima and the media and compress the lumen, as we just said, or it can actually be in the media and adventitia and then produce an aneurysmal outpouching of the vessel without compromising the lumen. In either case, the hematoma is within the arterial wall. So there is some dispute about whether it's outside in. So what I told you was that it came from the intramural clot, and that actually tore the intima, producing a flap. There are some people who think the other theory is that something happens within the lumen, like hypertension, which causes the tear. I think that's very unlikely. I think the evidence is that the hematoma itself causes the flap and injects blood into the lumen. Now, this can cause, if there is decreased flow, hypoperfusion. Most of the time, these people are fairly young and they're able to tolerate the premonitory TIAs fairly well. But when they develop an infarct, it almost always is red clot that actually produces the embolus and the stroke. And here are just some more pictures that show the hematoma in long longitudinal ways. And here you can see the luminal compression by the clot. Now, there are medial-adventitial ones where you get aneurysmal formation and pressure on adjacent structures. Now, in the neck, because there is fibrous tissue around the vessels, usually it doesn't produce bleeding, but it produces pressure on adjacent structures. And so the symptoms may be related to those structures and not really be neurological ischemia. So if we look at what predisposes and what some of the causes are, I think the major cause is mechanical stretch. So there's a sudden stretching of the vessel wall, which tears it, a sudden movement or stretch. There are also, if there is some problems with the vessel itself, that can also predispose to it. So fibromuscular dysplasia. There's some evidence that migraine can produce a dilatation of the wall of the vessel and lead to it. Ehlers-Danlos, the vascular part. Some people with abnormal connective tissue, loops, or different kinds of abnormalities, dilatations of the vessel wall. And there's some evidence that during the third trimester of pregnancy and the postpartum, that they're more susceptible. I've seen a number of women, doctors who are obstetricians who've developed a dissection just after delivery or at the end of delivery, maybe because of the increased hormones at that period of time. So this is just a description of kinks and coils. It seems like during the loops and during the coils, the vessel is much more easily torn if it's stretched. So this occurs at places where the artery is mobile. So if you think about it, I'm going to go over this again. The carotid artery is pretty much fixed at its origin from the common, and it's also anchored when it goes into the skull. But in the pharynx, it can move fairly well. So the areas that one gets dissection are different from those that you get athero. So athero occurs at the early part of the carotid bifurcation in the neck and in the intracranial portion, whereas dissections occur in the middle, really in the pharyngeal portion. The same thing with the vertebral artery, that the artery is anchored from the subclavian. It's anchored within the vertebral column, but the area between its origin from the subclavian and where it enters the intervertebral foramina, that can be torn. And then when it comes out of the rostral vertebra and then goes intracranially, there it can be torn. So atherosclerosis usually occurs at the vertebral origin and at the intracranial vertebral, not in the middle part of it. So I think the location becomes very important and the mobility of the artery becomes important. So if we look at carotid dissections, what we see in symptoms are, one, you do get hypoperfusion. Miller-Fisher called this carotid allegro because it's usually a faster pace. So often you can say repeated episodes of transient monocular blindness or repeated small episodes of hemispherical ischemia. And then if a stroke occurs, it's usually sudden onset and due to an embolism. If the dissection extends up to the skull base and into the carotid within the cavernous sinus, it can block off the ophthalmic artery. And so one can get ischemic optic neuropathy. And in fact, if you get loss of vision in the eye at the same time as you get hemispherical signs, it almost always means that the artery is occluded at that level. Now, when it's adventitial, you can have nothing in the way of major symptoms or Horner syndrome, pulsatile tinnitus, and it's very common to get lower cranial nerves affected. So we sometimes see people coming in with lower cranial nerves, either pharyngeal weakness, sometimes weakness of shoulder shrug, and occasionally it involves the hypoglossal, so you get tongue weakness as part of it, sometimes with just a little bit of neck ache. So it can really mimic a mass in that area. So these are some pictures, and here you see a dissection that is irregular and looped. You can see this dilatation of the vessel. Here one sees the narrowing or kind of almost like a string sign. Here's another one that's probably better, showing the string sign. And in this one, you just get dilatation and looping. And this is, again, a fairly looped artery. Here's one where there's an outpouching. You can see where the red is of an aneurysm. And here's another one with a fairly typical, what people have called the telltale aneurysm along. And here you see the bifurcation down here. And this is the pharyngeal part of the vessel. This is where it starts to go intracranially. Again, a loop and an aneurysmal dilatation, a very obvious aneurysmal dilatation. And sometimes the vessel is occluded. And if you look very carefully, you can see there is a little bit of blood flow going through it. But often if the lesion is up here, what it does do is increase resistance. So you often see the vessel collapse. It's sometimes difficult to tell where exactly the blockage is because of the increased resistance, but clearly it's somewhere within this pharyngeal part of the carotid. Now you can also get occasionally a false lumen, just like you do in aortic dissection. So you look here, there is a true lumen and then there's a false lumen, and that alters cerebral blood flow. That's not very common, but it's more common in the carotid than it is in the vertebral, and less common than you see it in the aorta. Now to go to vertebral artery dissections in the neck. Again, here, this shows it quite well. Here's the subclavian, and atherosclerosis usually occurs here. Either a plaque in the subclavian goes into the vertebral, or the plaque forms at the origin of the vertebral, and then it goes into the vertebral column, usually C6 or C5. So this area is movable. And then when it comes out of the vertebral column, here in the V3 portion, that's the area where you get a dissection. Here you can see it a little bit better on side view. It's that V3 portion that's external that causes where you get the dissection. So the symptoms are often neck or occipital pain. Sometimes the pain is in the shoulder, and in many people, that's often the only symptom. Then you often will get luminal compromise. TIAs. The TIAs usually affect the part of the brain that's supplied by the intracranial vertebral. So usually it's lateral medullary or cerebellar, a little bit of veering or dizziness or incoordination. When you get an embolism, the two commonest are either a cerebellar infarct or going up to the top of the basilar artery, affecting the posterior cerebral territory. It also can cause spinal cord ischemia, and it can cause root pain. So we've seen a number of people that have had neck ache, and then they have pain along in the arm. So they're thought to have a cervical disc. When you do a study of the cervical spine, you don't see anything, and then you do a vascular study, you see an outpouching, which has caused pressure on that nerve root. You can get, of course, just neck ache and headache. So these are some examples of irregular narrowing. This is in the distal part of the extracranial vertebral. Again, a cartoon that shows that. Here along the area, there are some telltale little tiny aneurysms and then narrowing. Here you see the vessel is almost completely occluded. And here with a fat saturated study, you can see a small lumen, and then you can see the intramural hematoma quite well. So if you get a cross-sectional study, often you can make the diagnosis a lot easier. This is one of the studies that shows this aneurysmal kind of dilatation. And here you can see it pressing, actually producing some pressure. So there was a wonderful case that led this home to me. This was a interventional cardiologist who went whitewater rafting in the mountains. And then the macho thing to do was to jump from the canoe onto a rock. When he did, he started to have neck pain, and gradually the neck pain went into his arm and he had root pain. So he saw actually an orthopedist who thought he had a disc and told him not to exercise and to keep calm. And then he lifted weights and was exercising, and all of a sudden his legs went weak and he developed an early paraplegia. The orthopedist thought that he'd compressed the disc, had compressed the spinal cord, and when they did an MRI of the cervical spine, they didn't see actually compression. and then a vascular study showed the dissection. So the vessels coming off the vertebral a little bit lower do supply the spinal cord. So nerve root pain can do that. It's a trap when people have had an injury, because you can get a dissection. And actually in people who have had serious neck injuries and are quadriplegic or paraplegic, some of them do develop dissections also, tearing of the vessel wall. So we have seen some people who come in the hospital paraplegic from an injury and then become blind and lose their memory from an embolus to the basilar artery. Now, this was a case that I had years ago, which I think really taught us a lot. This was a woman who inadvertently took an aspirin. She was very allergic to aspirin and took something that she didn't know have aspirin in it. She went into anaphylactic shock, and then she was resuscitated in the hospital. And when she kind of came to after the shock, she had a cerebellar ataxia. So they did a study that showed a cerebellar infarct, and then they did this angiogram, which shows this dilated area that looks very funny. At this time, the surgeon didn't know what this was, so what he did was to operate. So he took the vertebral artery, the distal part of it, hooked it into the carotid, and then removed this part of the artery for pathology. And this is what it showed. This is the proximal area, and you can see here this very angry intramural hematoma within the vertebral artery that goes fairly high up. There was a little bit of a dissection in the contralateral vertebral. And this is what you see in cross-section after it's stained. And here you can see this intramural hematoma and compression of the lumen. Very good, and it goes all the way up. Much more impressive actually than the angiogram. And a stained specimen shows this intramural hematoma. Now, we're talking about dissections of the neck. It turns out that intracranial dissections, for some reason that is unclear, are more common in Asian countries, particularly Japan and China and Korea. There have been a lot of reports of intracranial dissections, so they shouldn't be neglected. The presentations, again, are different. With an acute dissection, you can either get a brain infarct or a subarachnoid hemorrhage. And chronically, they sometimes develop chronic dissecting aneurysms, which can cause recurrent brain ischemia, recurrent subarachnoid hemorrhage, or produce pressure effects on the surrounding brain parenchyma and also the cranial nerves and also the cerebrospinal fluid system. So the medial-adventitial ones often present with subarachnoid hemorrhage, a sudden headache with bleeding. In the past, nearly all reported patients have been treated surgically or more recently by interventional techniques. In many countries, if you come in with a subarachnoid hemorrhage, you go on the neurosurgery service. If you come in with an infarct or ischemia, you come on the neurology service. So many neurologists have not had a wide experience with these lesions, and very few have been really watched. So we don't really know the natural history of this. It's virtually unknown. The anterior circulation dissections that are intracranial, most of them occur in the intracranial internal carotid, just after, near the top of the carotid. They can spread to the middle cerebral, or some spread to both the middle and anterior cerebrals. In young people, particularly, the dissections can occur within the middle. They usually have bad headache, just like you see in the neck, and different from the neck. The headache is usually either at the same time or immediately before the ischemia. So the two come pretty close together. There's a higher frequency of strokes than you see with extracranial carotid dissections. And subarachnoid hemorrhage, for some reason, is less common than with intracranial posterior circulation dissection. So it's not real common to see an intercirculation intracranial dissection that has a subarachnoid hemorrhage. The reason for that, again, is not very clear. And here's one example. You can see the arrow is pointing. Here's the carotid, and this is the top of the carotid. You can see it's really lopped off the middle cerebral artery. And here's a close-up of the irregularity in that artery. Here's a view sagittally, and you can see the irregularity of the vessel, and it actually also goes into the anterior cerebral artery. Here you can see it's almost occluded. And this is the infarct, which involves the intercarotid artery as well as the deep supply of the middle cerebral. It's a young person, so they actually have good collaterals and didn't develop much in the way of a cortical infarct. This has been the rule in these people with dissections. They're primarily young. Some of them have been getting it with running. One of the people had it with a marathon run, where some physical activity is very common. Now, in the posterior circulation, most often it occurs in the intracranial vertebral and extends into the basilar. It's sometimes in the neck, the high neck, and extends intracranially into the intracranial vertebral artery. And rarely it can involve the posterior cerebral or the posterior inferior cerebellar artery or the superior cerebellar artery. And one thing to say about these, at least in my experience and most people's experience, they don't change their nature. So if the patient comes in with ischemia, it's very rare for them to have a subarachnoid hemorrhage. If they come in with subarachnoid hemorrhage, it's not common for them to have ischemia unless they really develop vasoconstriction, just like you'd see in any other subarachnoid hemorrhage. So these can be intimal-medial, causing ischemia, or medial-adventitial, causing subarachnoid hemorrhage. And here's a patient with bilateral dissecting aneurysms that occur in the vertebral right near the basilar. This is a cartoon of a very early case, which is sort of common, that the dissection starts in the intracranial vertebral and goes into the basilar, and in this case causes a narrowing of the lumen. The dissection can start in the basilar, but it's a little less common. And you remember that the vertebral artery is actually outside the brain parenchyma, whereas the basilar artery is right near the pons and the clivus. So there's not much room for movement of the basilar artery, where there is movement of the vertebral artery, particularly after it penetrates the dura. So they usually are within the vertebral artery itself. And here again is a very similar fat saturated, and you see here a small lumen, and you can see the intramural hematoma. Here you can see it actually as a black, this is a susceptibility image. Here the vessel is dissected, and this is again the vertebral that is fully occluded. And in this case, you can see the irregularity in the early part of the vertebral before it comes the basilar. There's an area that is longitudinal. It's very unusual for a dissection to cause a very sudden, very brief area. Now here's one where you see the dissection. In this case, the patient had an actual hematoma within the wall of within the lumen, and that hematoma actually within the lumen caused ischemic strokes later. So these things, like other aneurysms, can harbor clots, particularly if they're big enough. Now, we saw a few patients with posterior cerebral dissection. One of them actually, Artam Asara, sent us, but we saw 3 cases, and this was an example. This was an eccentric psychiatrist who was at a meeting, and he became very restless. So he rented a sailboat, despite the fact there were big warnings saying you shouldn't go out. The winds were strong. He felt battered by the sea moving about. The sailboat moved fast and out of control, and he kept his neck in a fixed, unusual position while he vigorously used his limbs. And by the way, I think the issue of causing intracranial dissections, in my experience, there often has been some movement or sudden trauma that causes it. Later that day, his neck and the back of his head hurt. He had a brief vision, he said, of a scintillating, colorful waterfall that was to his left. And then nothing happened till a week later, during which he continued to have occipital aching. He had a similar visual experience of a waterfall. And then 2 days later, his wife noticed that he was clumsy, had left limb incoordination, and bilateral ptosis. On examination, his cognitive functions were normal. He had no visual field defect. He had severe ptosis of the right eye. His eyes diverged with the right eye down and out. He had a left gaze palsy with torsional nystagmus and a clockwise rotation more obvious in the left eye. On attempting down gaze, the left eye dipped below the right and had strong torsional nystagmus. The pupils were 4.5 millimeters and reacted, and his left limbs were incoordinated but not weak. The left limb reflexes were slightly exaggerated, and the left plantar response was extensor. His gait was slightly wide-based. So this localized really to the tegmentum and the cerebral peduncle in the midbrain, mostly on one side. And here was the area of tearing. This later opened up, but you can see the very small, probably, vessel coming off down here. And here was the infarct on DWI involving the cerebral peduncle and the tegmentum of the midbrain. And it also involved the cerebral peduncle here. And you can see here that the medial thalamus was involved from a branch of the posterior cerebral artery, really the polar artery branch. So I've gone through fairly quickly on purpose. I've not said anything about treatment because I think it depends very much whether the dissection involves the intima, whether there is clot in the lumen, or whether it's an adventitial one, and also the background of the patient, and of course their risk factors and other issues. So I hope we'll get into a discussion about management.
Excellent
Thank you,
talk.
Dr. Wonderful, Dr. Kaplan. That is great. I think we can open the discussion about the treatment because they have several questions about this, showing a case, and you can discuss in the case what's the best treatment. Could you be? I will share my screen and we start to, well, so the first case, woman, 35 years old, white, teacher. In 2005, 9 a.m., she was writing on a blackboard teaching children and had a sudden expressive aphasia and right arm paralysis with duration of 10 seconds. She arrived very fast in the hospital, completely normal without symptoms, received 200 milligrams aspirin in the ambulance. 9:40, CT was normal, and CTA showed left extracranial carotid arterial dissection. MRI diffusion with a small area of restriction, cortical left frontal, just a point there. And 10 a.m., she had again sudden expressive aphasia, 2 or 3 minutes, and with full recovery. So this is the initial case. I don't have the first image, just the description of left extracranial carotid arterial dissection.
Do you have headache at all?
Headache, yeah. Yeah, and 12 hours earlier, she played football and received a big kick in the head. And she reported mild headache since the 12 hours before.
I see.
Yeah. So what would you do now? Let's see the question now, because she had twice the symptoms, very quick symptoms, only a small point in the MR with carotid arterial dissection. And the question is, what would you do? Antiplatelets, she received 200 milligrams of aspirin in ambulance, anticoagulation, intravenous thrombolysis, endovascular treatment, or colon experts.
Could you show the imaging of the dissection?
Yeah, I don't have here, but I will show in the sequence in the next image. I will show you. Yeah, yeah.
But it's not fair. You should show the image first, then you should decide. Yeah,
no, I can show you. Here is the image. Yeah. you have to believe me. Quais foram as respostas, Telos? Well, the answer was antiplatelet, 40%, anticoagulation, 30%, IV thrombolysis, 11%, endovascular treatment, 11%, and colon expert, 9%.
Well, let me just reflect for a second. So if you look at it before you see the films or while you're looking at the films, what are you really looking for? So for thrombolysis, you would like to see a clot within the intracranial arteries that you could lyse, or a clot maybe even in the neck that you could lyse. Now, if you look at this and you're giving intravenous thrombolysis, there's no way that you're going to be able to lyse that clot within the carotid artery, and there doesn't seem to be an intracranial clot. So, but you do have a blockage of the artery, so you have lack of flow. So you want to augment flow. So you want to get the blood pressure up, fluids up, and then you want to prevent embolization from that. So to me, that would be an anticoagulant, raising the pressure a little bit and fluids more than anything else. Now, if she had a clot within the intracranial arteries, that would be a different matter in relationship to aggressive treatment or thrombolysis.
And she's an NIH stroke scale of 0, right? So she's symptomatic now. So
she had 2 TIAs. Was that? She had 2 TIAs.
Yes.
So basically, most of the cases we still with this doubt, between anticoagulation and aspirin in these cases, right? I would ask Dr. Kaplan, in which cases do you prefer to use anticoagulation or antiplatelet? Do you have any preference and criteria for choosing one or the other?
Yeah, antiplatelets actually just prevent platelets from adhering to the vessel wall, and in these cases, if the lumen is compromised or there's clot within the lumen, it's really a red clot problem. So the standard anticoagulants are much preferred. Now, if it's just an irregularity in the vessel wall where there's no major, whether it's involvement of the adventitia, then I would think about using aspirin because a clot hasn't formed. But in most of these cases where there's luminal compromise or a clot there, I give standard anticoagulants.
Yeah.
Just one more question, Professor Kaplan. Do you take into consideration the time from symptom onset to your evaluation to decide if you go to anticoagulation or antiplatelet therapy? Because sometimes when we are more than 7 days, for example, the risk of embolization is lower. Even we have a tear in the intima with a clot, the risk is lower. Do you think it's important to be considered as a variable to decide?
Yeah, I think it's always worth, all the studies have shown that if you're going to have a stroke, it's much more likely to happen right away in the first hours or day or 2 days. So the longer time that goes by, the less likely you are. So I think you weigh the factors that relate to either, complications or effectiveness in it. So if there's but in most of these people, if they're fairly young and there's no hint of bleeding, you can get emboli for quite a period of time. So it would be one factor that would lead you away to anticoagulation if it's a longer duration. But if there are no contraindications, also we've all seen people who then do have a stroke, 2 weeks afterward, or especially with sudden movement. So it wouldn't be an absolute. It would be just one factor. If you're weighing benefits versus risks, it would be one factor that would push you more toward the risk side.
And for how long do you keep intravenous heparin? And when do you transition it to warfarin? And do you always use warfarin, or do at any time use any of the new anticoagulants?
Well, the newer anticoagulants work very quickly, whereas Coumadin is very variable, and then I think it depends a little bit about the patient. So I don't know how it is in Brazil, but if the patient or the insurance can cover newer anticoagulants, I always prefer them. I think that they're, if the person's going to have to be on Coumadin for whatever reason, then I think you would use heparin until they're in good range.
So if you can
Okay.
use the new ones, you just begin with the new ones in the acute phase?
Yes,
Okay.
it works very quickly.
Okay. Oh, that's great. And about the neurointerventionalist, Rodrigo, do you have some opinion about this case? Do you think about to treat with endovascular treatment this patient in this time without intracranial clot?
I think that in emergency room that would be the question, and we have to think about what is the risk of this patient of have a big stroke. So we have to have some data about what is the risk. It's like the situation with an LBO and low NIH. So the more information that we have, the more better decision we take. So this patient have already had 2 TIAs. Maybe would be nice to know what's the mechanism of those TIA. It was embolism from red clot on the dissection or just the hypoperfusion. I agree obviously with Dr. Kaplan that this patient, the first measure that management would be volume, intravenous volume, and get a good perfusion with pressure. I would like to know about perfusion of this patient. I don't know if some of you would make a challenge with this patient.
Wait, what?
Sorry.
I don't think so, because I mean, you mean like stress test or something like this?
Yep. Yes.
Yeah, I wouldn't do, just because there is no intracranial occlusion, right? So I mean, if the patient has like a proximal occlusion, like an MCA in a tandem lesion with a dissection in the carotid artery, and the patient had fluctuated with a high NIH and then is now asymptomatic, we may have to, you know, to proceed with like perfusion studies or maybe to stress test or something like this, just to get a sense about the collateral flow. But as soon as in this case there is no intracranial occlusion, I think that I would probably go with anticoagulation as well.
The other factor that you have to consider for the intervention is how easy is it to do the intervention?
Right.
Exactly. Yeah, that's the problem. Right?
You're going to produce some problem by pushing the clot into the head. So that's the other factor you have to consider.
Right. That makes sense.
Yeah.
But the patient can still fluctuate with a cervical occlusion, yeah? Doesn't have to have an
so we just you mentioned right. We just published a series of cases that what we called hemodynamic thrombectomy. So patients that like have a proximal occlusion in the or have like a carotid artery occlusion, but presented with a attacks, total anterior circulation syndrome without intracranial occlusion. I think depending on the collateral flow that can happen, but it's very rare, right?
Well, we put this patient seated, and she was without symptoms, but once she start again with right hemiparesis, we put volume, and she improve and recover completely of the symptoms. What do you think about the treat with endovascular treatment this patient in this moment?
Yes, so I think it's important that we there is no full consensus, right? But my opinion, the indications for endovascular treatment of dissections are only if you have an acute stroke with intracranial occlusion, high NIH stroke scale, just like any other acute stroke, right? It's a no-brainer, you have nothing to lose. If you are having refractory hypoperfusion, the patient is symptomatic from hypoperfusion, you can't control with more fluids and induced hypertension. If the patient has recurrent ischemic symptoms despite best medical treatment, including either anticoagulation or do antiplatelets, and you have to be therapeutic on those, right? So short of that, we occasionally will treat like a chronic dissection with expanding dissecting aneurysms, mostly if they compress cranial nerves or cause recurrent embolus. Most of those chronic dissections, cervical dissections, are asymptomatic. They can be pretty big, and they are by far very benign lesions. One thing that I think it's important to acknowledge is the long-term patents of a carotid dissection. It is better if you don't stent the patient. These are lesions that tend to heal very well. Over 90% of the dissections will heal completely. Even if you have a complete occlusion, over 2/3 of them will recanalize and heal. So these are very big, the long-term prognosis of these lesions are very good. We tend to only intervene on these cases that come with high NIH stroke scale due to hemodynamic failure or intracranial occlusion.
And how about if the patient bleeds? So then we should, are you aggressive? Is it a subarachnoid hemorrhage and you have an intracranial dissection? Do you always treat? Yeah.
So that's a completely different entity, right? So I was talking about typically cervical dissection with ischemic presentation. So the ones that come with intracranial hemorrhage, as Dr. Kaplan said, they tend to be the vertebral intracranial dissections. One of the things that people in Asia will tell you, and I don't think there is great data about this, is that typically the dissections, they tend to stop at the dural ring. So they are either intracranial or extracranial. It's hard to have a mixture of those. And that may be one of the reasons why, as Dr. Kaplan also said, ischemia and hemorrhage tend not to occur simultaneously. But in those cases, it's absolute. You have to treat the vessel. A lot of the times, if we can, I think a deconstructive approach, a vessel takedown is always safer. It's not the sexier treatment. The sexier treatment is to put a pipeline or stent and coil, right? Those are the cases you show in conferences when they go well, but when they don't go well, the patient dies, right? And if you have to have a contralateral vertebral dissection that it's pretty healthy, I think the safest treatment is a takedown. But more and more, these flow diverters, they are getting safer and safer. So you are doing more and more reconstructive treatment.
How, on the other hand, we are talking about acute subarachnoid hemorrhage in the acute period. However, when we diagnose the intracranial dissection after the acute period, like 7 to 10 days, is more challenging because the higher risk period is already passed, and you don't know exactly what would be the best solution. I'm not telling that we should treat or not treat, but we don't have enough data to support that we could maybe make a choice of a conservative treatment. It's not easy for an interventionalist and for the family to discuss about that, but it's important to point out that after 7 to 10 days, the risk of rebleeding is very low according to the Mesotomitories series.
One point actually that we haven't talked about that a lot of people will ask you. So the ones that have aneurysms in the neck, the outpouching, people worry that they could harbor clot and then later have a stroke. The French people did some very nice studies that show that usually those disappear. If they don't disappear, they usually don't cause any harm. So we don't necessarily keep up the anticoagulants or do anything because of that. I think it isn't, you don't have to worry about it.
Actually, that would be my question for you, because sometimes it's challenging. Most of the outpouching in the cervical artery, mainly the internal carotid artery, they heal over time. But sometimes we have some scars that stay over time, and it's quite complicated to discuss because we don't have enough data about that, and the family is always anxious, and they are very prone to treat. And in general, what I keep one antiplatelet, just like aspirin for life. I don't know why I thought on that.
Sure, aspirin is reasonable.
So Franza, I do the same thing. There is actually a good paper about that in neurology, a very large series. I think it's a Neurology 2006 paper. I have to double check, but it's definitely neurology, specifically about the benign long-term natural history of this, these cervical dissecting aneurysms. And there are a bunch of neurointerventionalists who, you stent and put flow diverters. Technically, it's very easy to do, but I think it's a completely unnecessary procedure. I have patients like this that have been following for over 10 years. I have yet to see one become symptomatic. The ones that will become symptomatic are the ones that will expand the aneurysm quickly within the first few months. And occasionally they will have lower cranial nerve deficits, as Dr. Kaplan alluded to.
Well, after this arteriography, we started anticoagulation, as all of you suggested. We did not treat this patient with endovascular treatment. 2 p.m. again, right hemiplegia, and she was starting anticoagulation now. They were preparing since 11 a.m. in the morning. So she started again with right hemiplegia, and she went to MR and MRA. This is diffusion in ADC map. And here,
why did she get angiography in the first place? I mean, because she was asymptomatic.
Yeah.
Go to
well, we discussed because she was improving and starting symptoms and improving. We decide to do angiography to better evaluate the situation.
Okay.
Yeah, just for this. We were 5 stroke neurologists, 2 neurointerventionalists, and 3 neuroradiologists trying to decide the best treatment for this patient. In this time, now she had a occlusion here in MCA.
Right?
Yeah.
This is a different,
she's a different
game.
situation. Yeah.
Absolutely. Yeah.
Well, she recovered of hemiparesis and had only paresy in her hand after the angiography. In this time, what would you do now? Let's vote. Pergunta 4, pessoal. Vamos colocar para votar a pergunta 4. So now she has intracranial.
Now she has an MCA and a dissection.
MCA, now NIH. Yeah,
Chapter
one, because she recovered only the hand and just
she has a tandem.
A small.
She has a tandem.
Yeah.
It's in an 8-stroke scale 1. Or a little hand weakness, which is explained by the DWI lesion.
Exactly.
Yeah.
So
yeah.
There is no
but remember, she was hemiplegic.
Yeah, she was hemiplegic and recovered, and just
Then now she draw down to
and
1.
And the anticoagulation was not started yet until here. Sorry.
What do you think is wrong with the middle cerebral artery? It's not completely occluded. If you look at the picture.
Let's check. Good point.
Here.
It's irregular. There almost surely is some clot there, but it's not completely occluded. She's getting some flow, so that might make a difference as to what you would.
In fact, if you look at the axial view there, right, you got to remember that this is a flow-related study.
Yeah.
I actually don't think there is no occlusion there.
Yeah.
In this case,
it could be decreased flow. Yeah, you're right.
The angiogram, then an MRA. There is absolutely no occlusion there. There is decreased flow-related enhancement. Right. There is no.
Yeah, you're right.
Well, the participants choose now 5% antiplatelets, 23% anticoagulation, 80% to IV TPA, and 65% endovascular treatment now. So let's see. Well, she recovered, as I told you. And we call neurointerventionalists to discuss the case again. On this time, we were everybody, 10 people discussing the case, and during the discussion, 4 p.m. right hemiplegia again. So I will not ask. Yeah, she went to arteriography again.
Let me just ask a question about the one before that. So if you gave intravenous thrombolysis, how much do you think would get to the area that you're worried about, intracranial? Would it get there through collaterals, do you think?
Yeah.
Sometimes you can open the MCA and improve the intracranial flow when you use IV thrombolizing patients with carotid occlusion sometimes.
Yeah, but I see your point. I mean, TPA doesn't work very well in tandem occlusions, right?
No, I agree with you. Yeah, in this case, we didn't use.
One of the things we don't do very often, but they do in Europe a little bit more, is use transcranial Doppler, because it's hard to keep doing angiography.
Yeah, agree. Yeah.
But if you have a baseline transcranial, you can kind of follow that and monitor it a little bit.
I will tell in that time we didn't have a transcranial Doppler because it was 2005. Now today probably will be the best way to monitor the patient. So that time she had again hemiplegia. This is the angiography here with the dissection. Here MCA occluded and ACA occluded too. So we decide to start the end of how.
The MCA is not occluded. Okay, there may be a partially occlusive clot in the ACA, right? You just see you just see one image in here, but you can see the whole MCA. Okay, what is happening there is probably flow from either the ophthalmic or the PCON that is diluting the blood. There is competitive flow, but there is no.
Yeah.
You can trace the entire MCA, right? So do you see that you see the ACA very well, and then you have like a faint
stop, right?
Well, it's not a stop. It's the reason for that is because you have competitive flow coming from
of the contrast.
But well, Paulo is not here, but he told us that the MCA had a clot.
Okay, so you see you see that when he crosses and injects from the Arvinus ICA, everything is open. You see the
you have to cross it, right?
The MCA is open.
It could be, yeah.
No, it couldn't. No, it is, my friend.
Well,
I mean, Paulo says it was occluded, and he probably passed the dissection. So I mean, Paulo said it was occluded, so it could be partial occlusion, right?
Yeah.
I mean, I see your point. It might be only competitive flow, but apparently he crossed the dissection and injected, and there was no flow. So.
No, you see the microcatheter injection, and you can see the cross-filling with competitive flow. If you show this to anyone, Franzé, can you give your opinion? Is this left MCA occluded?
For the pictures that we have here, it sounds to have a dilution of the contrast in the MCA. As you may, certainly through the ophthalmic artery, as you can see in the AP view, the second picture from the left to the right. So it seems not to be occluded.
Wow, what did you do in this? What do you do in this case? How? What's your opinion about to treat or not with endovascular treatments now? How?
I think it's very.
How do you feel like? Do you feel there's a stop on the ACA? What do you think about ACA? Do you feel it's still
no?
There's no clot in the ACA as well.
There are two different points here, right?
Right.
The question is, would you do endovascular treatment?
Yes.
It's one point.
Yeah.
Right. The second point is this MCA occluded? Okay, they are actually interrelated because. If the MCA is not occluded, and in fact, so the first thing you should do in a case like this is shoot out the other vessels. Okay, you need an external run to see what the ophthalmic is doing. You need a posterior circulation run to see what the PCON flow is doing. That is going to give you a much better appreciation for the flow. Okay. And what you are seeing here is what you saw in the MRA. In the MRA, you saw decreased flow-related enhancement.
Right.
There is definitely decreased flow, right? Okay, So, but there is no occlusion. There is no occlusion. I'm sure if Paulo was here, he would tell you there is no occlusion. Because there isn't. Okay.
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 Nonetheless,
how to cross the occlusion with the microcatheter? Then, you know, after you do that and you get away with it, you just stent the vessel, because that's the risky part of the procedure, is to cross the occlusion. So I would never do a selective catheterization, as you see in the bottom picture here, for diagnostic purposes, because crossing that occlusion is the risky part.
The most difficult part.
Right? When you put the stent, you can toothpaste the clot into the brain. So it's not that it's without risk, but more and more now we are using flow diverters for these things. And then you reconstruct like distally to proximally, and you can trap the clot pretty well. So I think in this case, the patient claudicated and had 2 hard TIAs, right, with hemiplegia. So I think it's very reasonable to treat this patient, but she did not develop an MCA occlusion, right? She has hemodynamic claudication.
Yeah,
that's the reason why she gets worse and better, right? Typically, when you have like a fixed M1 occlusion, you don't claudicate that much, right? But
right. So I agree with you that it could be the case. The only thing is that we cannot rule out as well a more distal occlusion. And I think that in this case,
actually you can, because you have the microcatheter injection showing the entire.
If you do that, right? If you do that, right?
He did it. But however,
but
I can see your point, Otávio. It seems to have a clot in the A2, the
right.
left A2.
Right.
And it seems to have as well a clot in the proximal A1. Otherwise, through the injection of the right ICA, we were supposed to see the fully opacified MCA. It's not the case. So it must be something that is impairing the flow there.
Exactly. And I mean, the most important thing here is that, so the patient's claudication with a proximal occlusion may be in the neck. It could not be a tendon, but it might be some distal occlusion. And I agree with Raul that it could be just a low flow. But as soon as the patient is claudicating, right? So we have another condition now, right?
Yeah.
So it could be that the patient is exactly at the point that I mentioned before, the publication that we had, like the hemodynamic thrombectomy. So it's patients with a proximal occlusion in the neck that claudicate as a total anterior circulation syndrome. But in this case, you know, sometimes you need to intervene, right?
Well, yeah, but the question, I think I understand what Raul was saying. I mean, it's to intervene. I think it's very, reasonable. The patient was hemiplegic, and then for the second time, but it doesn't mean that we're gonna open the MCA. Yeah.
No, not necessarily. It could be just it could be that you have a proximal occlusion in the neck, and then you have a distal occlusion. Just the A2 or something like this. We cannot rule out an M2 occlusion, for instance, right?
Wow. She used 3 stents because of dissection. They open one and close in the next part. So she had NIH stroke scale 1 at the end with only the hand, but you can see here the final MRI and finish this case. And just to discuss again treatment in a different situation. Now, Raul, Otávio, and Gisele, wow.
Just one point about that case. So,
okay.
The vessel, right? There was no thrombectomy done. Correct?
2005, there was no thrombectomy.
Yeah, no, we didn't use, we didn't have thrombectomy. Yeah. We didn't have device, but use the
intra-arterial thrombolysis.
No. Use only the catheter.
Okay.
To in the thrombus. I didn't remember exactly what we did at that time, but sometimes.
So this was not like intra-arterial thrombolysis.
It was not
thrombectomy. This is stent reconstruction. Again, this was a ICA occlusion.
Hemodynamic.
Yeah, but I remember that he went until MCA and ACA too. I didn't remember what he did exactly at the time. I was together in the room, but of course I cannot remember. But I understand your point, and probably when open carotid artery improve the flow in intracerebral flow, and she improved. I really did not remember what he did.
The
intracranial vessel. Yeah.
Okay. But just to emphasize before we go to the next case, Sheila, you had to wait for 2005, 15 years ago.
I cannot remember exactly the details. 15 years. I remember the case because she was very important for us. We put everybody discussing the case, but the details I really did not remember. I don't remember.
Well, cases clearly exist, but they're fairly rare. So Amarenko had about 5 of these cases, but I think the vast majority of the cases don't need the intervention.
Yeah, I agree. Completely agree.
Some do. These cases exist, but then what we all did to go over what exactly was wrong with the patient. Was it hemodynamic? Was it clot?
Yes.
Getting the most information helps you make the decision. Right. So these cases exist, but they're not very common.
Perfect. Completely agree with you.
Yeah.
This is an interesting case also, how Otávio and Gisele participate, a woman, 28 years old, flying from the US to Chile, had sudden pain in neck, posterior region, right side. She called to her doctor, my husband, and he talked to her that could be a dissection. And she go direct to the Clínica Alemanha in Chile to be evaluated there. She performed CTA, and she really had a right vertebral artery dissection, V1 and V2. This is the image. So without neurological symptoms, she started. What your opinion? Can you put the... vamos colocar as perguntas de novo. What you do now? Let's vote.
No neurological symptoms other than...
No neurological symptoms. Only the neck pain.
The neck pain.
Yeah.
Please show the image again.
Yeah, the image is here.
And how was the lumen?
That was my question again.
Yeah.
It was not occluded, but had the hematoma in the wall hematoma.
But how much stenosis does it have?
It was, I don't know, Gisele. This is the
it was
image.
A long
it was not.
stenosis.
Yeah. In this moment, it was not. It was a small one. It was a small one. Yeah.
The problems.
Yeah. Well, the answers: 50% aspirin, 26% aspirin plus clopidogrel, 22% anticoagulation, 3% endovascular treatment. Well, Gisele, what's your suggestion in this case? What would you do? What would you do?
What I generally do for such cases without strokes, I generally do TCDs. We use TCD a lot. If there is no microemboli, we just give antiplatelet, and we generally use dual antiplatelet.
That's
what I would do.
Okay. So she started with aspirin. In 24 hours, she was transferred to our hospital in Brazil, and she arrived referring more pain in neck. I don't have the images here. So she had a right vertebral dissection since V1 and V2. So she had a large dissection now with a wall hematoma, but without any neurological symptoms. What would you do now? Please, vamos botar a votação de novo, pessoal, pergunta 6.
Do you have the imaging or just the...
No, I don't know what happened with images, but I sent that time to Raul, Gisele, Otávio, all of them saw these images because it was a long dissection. I think I don't have it here. Yeah, yeah, we have a long dissection in the right side in vertebral artery, V1 and V2, almost until V3.
And how was the left vertebra?
Yeah, in this moment, left was normal in this time, because we remember that after we have a left this dissection too. Let's see the results. Could you send me the results? Well, 53% antiplatelet, 37% anticoagulation, 10% endovascular treatment. Well, we start with anticoagulation with enoxaparin.
How much said that we should treat endovascular?
Endovascular, 10%, I think. Let me see again. 10% endovascular, 37% anticoagulation, 53% antiplatelet. Well,
yes, I think there is the economic crisis of COVID, so endovascular guys need to perform procedures, you know.
Yeah, so we start with enoxaparin to this patient, full anticoagulation. 48 hours after start enoxaparin, she referred black stool. She think she had black stool. We stopped enoxaparin to evaluate if really she had a melena. But in 72 hours, she referred again severe pain in the neck. Now in the left side. So MRA right side was the same, the dissection V1, V2, almost up to V3, and in the left vertebral artery, a dissection decreasing 50% of vessel lumen.
Was also dissected.
Yeah, dissection.
So it was a bilateral dissection.
Bilateral dissection. 50% one side and less than 50% the other side.
You know, it's very common. Actually, it's more common in women, but it's much more common in vertebrals to get bilateral.
Right.
And actually, Jeff Saver gave a talk about this from Los Angeles about the plane. So you also ask, was a patient sitting in an aisle seat or in the window seat? And were they in coach class or what? Because if they're in the window seat, then they often hold their neck in a funny position and they lean over the window, so they get the sections there.
Yeah,
exactly. And you know, I noticed that most of those patients get some sleeping pills in the economic class, like coach class. So they get these funny positions and they are sleeping because of the pills and they don't move. So most of the cases.
In this case, it was not. She was in a private airplane.
She was in a private jet, actually.
Yeah, private one. In this case, the situation was worse because in this time, the husband was a very important person in Brazil, and the whole country was giving opinion about the case in this time. So what I did, I called for my friends for a teleconference to discuss this case because it was very challenging. So Gisele, Raul, and Otávio participate with us. And here is Paulo Passos that was helping us there to decide to treat or not treat with endovascular treatment this patient, because everybody was calling to the family, telling them, go to São Paulo or you have to treat this patient with endovascular treatment. So we by teleconference, we discussed this case. She did arteriography, the same results of MRA, and we maintain anticoagulation. Was the opinion. I don't know if Raul wants to talk about it. Probably you remember, or Otávio or Gisele that participate in the discussions. When she
didn't have any ischemic symptoms.
No, any ischemic symptoms in this time, any ischemic symptoms, only progress in the dissection, yeah. And the discussion was to anticoagulate. In that time, she was without anticoagulation because she had a black stool, but we increase again the anticoagulation. This time, I don't know if you want to comment, Dr. Kaplan or Raul, Gisele, Otávio, that participate in the discussions in this time.
No, the only thing I would say is, it's also important to include the patient and to go over the risk benefits with what they're thinking.
Yeah. She was young and she had a large wall hematoma. We were worried with this. For this, we use anticoagulation. And in our discussion, we decided to maintain with anticoagulation. So after this, she started with left hemianopsia and scintillant scotomas, 20 minutes, 2 or 3 times a day, without history of migraine previously, and intracranial MRI normal.
And the carotids,
so in this,
there was no dissection in the carotids?
No dissection in carotid, only vertebral, bilateral vertebral artery. So in that time, we call...
Very important at this time point is the clinical presentation. Yeah, I have to listen to what the patient is saying. I mean, it's 20 minutes, it's bright, so it's not black.
Yes.
This is not ischemic. Yeah, this is migraine aura. Yeah.
No, but the first time she told us that she could not see. She could not see. We had doubt if she had hemianopsia, but probably migraine, but really, I was very, very worried. That time, we call Lish One, participate in the discussion also. And the discussion, maintain anticoagulation this time and start prophylaxis for migraine. We start before this discussion, but we were very worried with embolization. The TCD was normal. This time we already are using TCD. Transcranial Doppler was normal without embolization, but it was a very challenging case.
Yeah, so the important message, I think, in this case that we learn is that first, not every scotoma in patient with dissection, it's embolism to the brain. It could be just some activation of the like when you have like for instance any manipulation in the neck or or any problem in the teeth that may increase the development of migraine and migraine with aura. And I believe that in this case, the dissection, because she didn't have any history of migraine with aura, right, Sheila?
Yeah.
So
any history.
Apparently, exactly.
Any history of headache, any history of headache or migraine, yeah.
I think it could be that some minor emboli could be the cause of the migraine with aura, but I believe that some activation of the due to the stimulation caused by the extramural hematoma in the neck, and also the pain in the process, that could also trigger the migraine with aura as well. So that's my home take message for this case.
Yeah.
And as a neurointerventionist, I would think simpler. She was stressed.
Me? I was stressed.
Sheila was even more
patient.
Yeah. Well, we treated migraine with prophylaxis. She was asymptomatic. We anticoagulate the patient. In 3 months follow-up, left vertebral completely recovered, and right with V2 occlusion and V3 and all the rest of the artery recanalized. So just to show this case, and I think that is very interesting. Dr. Kaplan, an important discussion is after CADIS study, a lot of people change their minds about to anticoagulate patients with dissection. What do you think about the CADIS study? Can you the study gave us some answer to the treatment question?
Well, I wrote something very afterward, because I think the difficulty with the CASA study is, one, they didn't really differentiate. Some of those cases were just adventitial had very low, risk. They just lumped everything together. And then the treatment wasn't started till quite a bit of delay. So anybody who'd had a stroke before that was out. So what I wrote was, I don't think it says much about the acute period of what to do in it. And I don't think that you, as we've been saying, you treat each one the same. It really depends a lot on what the vascular lesion is, what the so the more information you can get, the more you can make a decision. I think some people are well treated with aspirin, some need anticoagulants, some need interventional treatment, but it depends a lot on the case. That's very hard to study in a trial unless you have lots and lots of cases that are different.
Perfect. Yeah, but before, after CADIS, a lot of people don't anticoagulate, never the patients with arterial dissection. Because of this, I'm asking you.
Well, we had a case of a pediatric doctor who came in the emergency room with a dissection, and then she was told that you could either take aspirin or anticoagulants. There isn't any real separation. We don't know what the best treatment is. So she said, I'll take aspirin. Next day, she had a big stroke and was devastated and is now completely disabled. Yeah. So I have seen cases like that, and I've not seen any major complications of anticoagulation. These are mostly young people. They're not hypertensive. So I think if there is a debate and there is any medial intimal part of it, and if there's any luminal compromise or clot, then I anticoagulate them. If there's not, if it's strictly intramural, there's no luminal problem, there are no ischemic symptoms, many of them can use antiplatelets. So I think it varies a lot on the patient.
Perfect.
Now that we're doing more non-invasive studies, sorry, Panzai, do you want to speak?
No, it's okay.
I had one question. When was the earliest control exam that you've seen normalizing after a dissection for you all? I mean, when you repeat an exam, how earlier have you seen like a vessel completely recanalized?
I've seen some cases very early recanalization, but I also have seen some cases that late. So I think it's very variable. Maybe what do you think?
Yeah, no, I'm asking because I mean I have seen some patients that were very worried. One because she was like an executive and she was gonna travel, and the vessel was occluded, and she repeated the exam with 15 days, and the vessel was completely normal in 15 days. So that was the earliest I've seen. So I generally repeat the exam within like 3 months, and this case was I was really amazed by it.
It's hard to know the duration. I mean, that is very difficult to study. I used to think that you keep studying them till the lumen open widely, but actually the number of people that have a stroke after 3 months is pretty low.
Pretty low.
So that, I mean, whatever happens, even if it doesn't open up, they sort of adapt. So right. I've sort of used a period of, something around 3 months, and then change them.
Right. One question is whether you, in a patient with an asymptomatic dissection, would you give aspirin to the patient for how long? How long would you keep the aspirin for those patients?
Excuse me, Octa, what do you call a symptomatic dissection?
I mean, sorry, not, so a patient that had on pain in the neck, okay, for a vertebral dissection without any ischemic symptoms at all. Would you put the patient on aspirin for how long? I have my own opinion, but I want to hear from you guys.
Well, two things. One, if you're the patient, they tell that you have a tear in your artery, you don't need any treatment. Just go home, do whatever you want to do. Otherwise, so most people want something. Right. They kind of lock onto that. There are other people who actually would rather not take it if they don't need it forever. So when they say, how long do I have to take it? Let's see, let's use it acutely, and then let's see. I want to make one other point that happens in the United States. I don't know if it happens in Brazil, but there are a lot of people who then scare the devil out of the patient. They tell them, please don't move your neck, don't lift the baby, don't have sex, don't go out. And the people are completely disabled by that. And there's no evidence
that happens in here as well.
Yeah,
Yeah.
I mean, you don't want them. You don't want them to play vigorous soccer and hit their head, but also you don't
Yeah.
really restrict them. I think that's a bad thing.
Right.
Yeah, we have several questions about this. If you prohibit exercise after the cervical dissection, or swimming, sports, or something like that after dissection, do you think the patient can make exercise like swimming or after dissection?
I think,
Yeah, I think if you do it right away, you probably don't.
Right.
But I think after a short
It's
time you
common
can. But
sense, right?
I think you don't also limit ordinary activities. I mean, you don't need to put in a collar and tell them not to lift the baby or not to do every activities. Now, vigorous sports, if they turn their neck a lot, I don't think you let them do that right away because it can stretch the dissection.
Okay.
So I think you have to be cautious, but don't limit ordinary activities.
So
However, Professor Kaplan, just one question.
Of course, go ahead.
Regarding this subject, sometimes we have risk factor related to some vascular anomalies. One of them are fibromuscular dysplasia. And we do know that is a risk factor for dissection. And I remember a case that I shared with Gisele, that was a professor of medicine here in Fortaleza, and he has many spontaneous dissection, really spontaneous dissection without trauma. And he was a swimmer, you know, and he has asymptomatic bilateral dissection. And the phenotype of the artery was of fibromuscular dysplasia. Unfortunately, we don't have a clear way to make the diagnosis of fibromuscular dysplasia, but in this specific situation, don't you think that would be a wizard to advise not to have repetitive, how do you say it?
Press on the artery, right?
Exactly.
Yeah, so the difficulty is people with fibromuscular dysplasia usually have abnormal vessels along it. So I have my own bias I'll just share you with about fibromuscular dysplasia. And it's interesting how one case, every case, you know, really teaches you and sticks with you. So this is a lady that came to our attention about 15 years ago. Dr. Michael Pessin saw her, and she had some minor symptoms, and she seemed to have an area on her carotid, I think it was the right carotid, which was like a shelf that looked like fibromuscular dysplasia. So what they did was they did an angioplasty, and it opened up, and she didn't have any trouble. 10 years later, she came in with some symptoms on the other side, and she had a shelf, and the shelf looked like it was in the same place as the other side, and she had some irregularity in the artery. So we asked an expert on this was Insup Choi, to do an angioplasty. So what he did was he put the catheter in, and he put in some dye, and he could see the shelf was almost blocking the artery entirely. So he got his instruments ready. He did another injection, no shelf, gone. So what actually happened is that the muscular part of the vessel contracts and partially blocks. So it's a contractile thing. So in that patient, verapamil or calcium channel blocker actually works. So I've seen now a lot of people with fibromuscular dysplasia that I put on verapamil, and actually there's a low incidence of recurrent stroke and recurrent neuroma. But I think it is muscular contractility that also has a role to play in it, and then the median adventitia are abnormal, so that's why it tears.
Interesting.
That's great.
Dr. Kaplan, how frequent have you seen RCVS, called Fleming syndrome, with a dissection? So this week I had one patient, very interesting case. So she had a nose surgery and she got intubated for it. And after the surgery, she had some neck pain, very mild, and she was using a lot of nose drops because of the surgery. And 1 week later, she develops a sudden headache, just like subarachnoid hemorrhage. She comes to the hospital, and then there is a left vertebral dissection and probably an RCVS. Vessels were all stressed up. So I've seen it with dissection alone. This patient was using the nose drops that could, explain part of the Carl Fleming. But how frequent have you seen it?
Well, there was, the original observation was by Ducros. It's in brain, and actually she's been very much involved in this. And I think what we didn't realize we all thought that RCVS was only intracranial. But actually what happens is there are changes in the extracranial vessels, and the dissection is part of the RCVS. So people make the mistake of saying they have brain problems because of dissection, but I think the dissection is part of the vasoconstriction and part of the RVS. So I don't think you treat I don't think the dissection, or I don't know of a case where the dissection has actually caused an embolism or brain infarct. So I think you just treat the RCVS and the dissection gets better. But it's very common. If you look at it, it's very common. And people are trapped. They think the whole thing is caused by the neck dissection, and they don't diagnose the RCVS, even though the clinical picture is fairly typical.
Perfect. Some comments, some final comment, Franzé, about
It's amazing. It's amazing how much we learn together.
Yeah, it's a lot of time and several questions, but during the discussion, we already answered several questions here.
At some meetings of the Heart Association, they tried that on us. What happened was each individual, they answered the questions of making a list, and then they had the group discuss it, and the group was always better than the individual. So we always learn from somebody else when we, especially if we discuss cases. I think it's much better than the general discussion, because then we see reactions.
Yeah, perfect. Here we have questions about dual antiplatelet, clopidogrel plus aspirin. Do you use it instead of anticoagulation in patients with wall hematoma, dissection with wall hematoma, and neurological, and stroke with arterial dissection and wall hematoma? They are suggesting that we could use dual antiplatelet and not anticoagulation as first option. I don't know. Dr. Kaplan, what do you think about it?
I wouldn't think about it. I don't think platelets have such a major role in this. The dual antiplatelets are very important when you have a stent, and you could get a platelet thrombus. But I think in a situation like this, I don't think there's a big issue with platelets.
Gisele,
you can get a fair amount of bleeding and other with dual in some people. So I wouldn't use it in this situation. I think there are other situations where it's useful, but not this one, at least for me.
Perfect. Gisele, what do you think about dual antiplatelet?
I think when we don't have strokes, I mean, when we don't have ischemic lesions, I think they might be an option. I mean, and I usually do TCDs in order to make sure that we don't have embolies. And I agree that, the studies didn't find out what the comparison would be if we used it in the first week. So that's a real gap. We don't know. So I think if the artery is occluded, if you have an important stenosis, it makes sense to use anticoagulation. Yeah. But if you don't have ischemic lesions and you don't have stenosis, you don't have mass on TCDs, I think that dual antiplatelet can be used.
I think the point, by the way, about using the TCD and emboli monitoring is very important. I think we don't use it enough. And all the information can be very helpful. Absolutely. You can also see if there are emboli, if they go away.
Right.
Yeah, perfect. Otávio?
I think we could create like a hierarchy for the decision. So, patients that are usually asymptomatic with dissection, with only neck pain, I would just give aspirin or one monotherapy. For those that have mass, for instance, on the Doppler, and I'm very concerned about, there's no ischemic stroke yet, but for those I may use a short term of double antiplatelets for those cases. And for patients that have ischemic stroke and are embolizing, I usually give anticoagulation. But the point I want to raise is that I don't think that we should give aspirin for life for a patient that has asymptomatic dissection, just because of the tear in the vessel. I usually because I don't feel like the aspirin is prophylactic against other dissections, right? So aspirin doesn't protect you for having another dissection. So I believe that, if you have a asymptomatic dissection in the neck, and then you may give aspirin for a few months, but, after maybe 6 months or 1 year, you may consider taking it off if the patient doesn't have any other issues. That's one thing that
Rodrigo, what do you think? Are you treating patients with endovascular treatment with the dissection? Do you have experience in treat patients?
In our clinic, we use more. We wait. We have to. We like to get all the information that we could about how is the artery. Obviously, it's not the same that we have an hematoma that's extrinsic or of if the vertebral dissection is in the greater vertebral artery. We look every time for the polygon wheel that is complete. It's very important. So we used to anticoagulate this patient, and sometimes, as Octavio said, we use double anticoagulation in some patients, but not for life. When we changed to monotherapy. In Cadiz trial, the antiplatelet treatment was not the same in all patients. The neurologist could use anything he want, and maybe in that trial would be nice to know why did you use monotherapy, or why did you use dual antiplatelets in this patient. We do not have that kind of information, and I wanted to say that these cases reflects that in real life the Cadiz trial did not give us all the answers that we need. Yeah. And as Dr. Kaplan said, every patient is different, and we have to get more information.
Small number of patients with it's difficult to have some conclusion in this trial.
Yeah.
Okay, great. Franzé, do you have experience in treating patients with endovascular treatment in the artery dissection?
So fortunately not, because the indications are always well done. I have done just outside acute ischemic stroke. I mean, with large vessel occlusion, I have treated just one patient with TIAs from hyperperfusion. He has bilateral dissection of the V4. So what the most important point is to realize that we have different types of dissections at different times. So we are supposed to adjust our treatment choice according to these two main variables. And it's important to say, stress and point out and remember that endovascular treatment is an exception for dealing with cervical dissection. Another important point that I think I am a vascular neurologist as well, so as vascular neurologists, is that we don't need to investigate, to make a full workup with a patient with cervical dissection, because cervical dissection is a diagnosis, is a cause of a stroke. And I see a lot of people who request thrombophily and transesophageal echo to evaluate if there is a PFO. If you know that there is a dissection, you don't need to investigate anymore, you know? So there is clear criteria for dissection. The most important one is the mural hematoma. And the hallmark of dissection is the healing process. So the artery remodel during the process. If sometimes you have a doubt of the diagnosis, the most important evaluation is the follow-up imaging, because it will heal during this process. It will change the shape of the artery. Maybe in case of occlusion, as it was said, about 2/3 to 70% of the case of cervical dissection with occlusion, they will reopen during the process. So I think these are my remarks in this discussion, and I'm very honored to be part of the discussion with Dr. Kaplan, and of course my dear president, that now represents Brazil all over the world.
I think the only thing to add, and I agree with you completely, the only thing is the patient will sometimes ask you, am I at risk for having another one? Do they have Ehlers-Danlos? Do they have osteogenesis imperfecta? I mean, you look a little bit to see if there is any hint that they have some other process.
And the other thing about leaving antiplatelets is this, Otavio. Yeah, it doesn't protect you from another dissection. But if you have a dissection, it might protect me from another stroke or for having a first stroke. So
yes, of course,
why
exactly.
the patient still has to be with something.
Yeah. I mean, I totally agree that in some cases the patient had, had a stroke before and had a stenosis or some, lumen narrowing or something like this. I would definitely consider giving antiplatelet for a long time, but I don't feel like we need to give aspirin for life for every single dissection. That's my point.
Yeah, I agree.
Right.
Well,
or statin. There's no indication for statins.
Oh, statins. Exactly. Yeah, perfect. Well, I think Raul is not here more.
Yes,
Raul, Raul, please, your final comment about the final remarks about the arterial dissections.
And say hello to the girls. Say hello to the girls. Say hello to the girls, Raul.
Oh,
hey guys.
Well, it's mostly, I think what we mentioned before, I think it was recently mentioned by Franz as well, is to remember that endovascular treatment of dissection is really, should be reserved for very special cases, like the acute ischemic stroke with intracranial occlusion, INIH, hypoperfusion syndrome that you cannot control with induced hypertension in fluids, and recurrent embolization despite best medical treatment, right? One of the things that I want to say about these last cases, there were people mentioning that they would have treated that bilateral vertebral dissection endovascularly. And that patient actually had two red flags. One is no acute neurological focal deficit that was pressing you to do so. But more important, she had GI bleeding. Once you put stents, and typically this is long stent reconstruction in those vessels, now you are married to the idea of dual antiplatelet treatment. And then if you stop dual antiplatelets, you have stent thrombosis. So that was definitely a case where you don't want to treat endovascularly. So again, you have to understand the big commitment that you're gonna have with dual antiplatelets once you stent a dissection. And once again, a lot of the long vessel patents, it's better if you don't stent than if you stent. We actually have a paper on that.
Perfect. Well, thank you, everybody. It was amazing. I think it's very important to see that sometimes we have challenging cases and sometimes you have a very severe case in patients with arterial dissection. And sometimes you need to share the opinion and discuss together with friends as we did several times. And I'd like to thank you, Dr. Kaplan, very much. Was wonderful. Thank you, really. It's a pleasure for us to have you here with us.
Honor to have you.
Yeah, it's an honor, and really thank you.
We're gonna bring you back to Brazil as soon as the pandemic goes away.
That'd be wonderful. Is that a promise?
Yeah,
yes, it is.
Promise.
Okay.
It's a promise. Okay, so thank you to everybody, and bye-bye till the next Global Stroke Alliance. See you. Bye.
Thank you for organizing,
Bye.
Sheila.
Thank you.
Bye.
Bye.